Hi, good morning. My name is Meet, one of the FNP student. I'm here to do your lungs and thorax assessment. Uh, I wash my hand, and this video what we're doing is going to be recorded and posted on YouTube for my professor. Will you give me a consent to do that?
Yes.
All right, thank you so much. So we start our assessment. We need stethoscope for that things. We need uh, measuring things, a pen, and we're going to follow four steps here, which is inspection, which is very important step for all the assessment we do, palpation, then we do percussion, and then at the final we'll do auscultation. uh, so for inspection of the chest, we do anterior and the posterior. So while doing the anterior inspection, we check here how the patient breathe. Is the patient breathing shallow, patient breathing hard, is there visible skin breakdown, cut, wound, or any surgical mark? That's what we check on the anterior side. And look for the posterior side. The same thing here. Is there kind of any cut, wound, or surgical mark? And the way patient breathe, patient air, and looks like patient is very comfortable and not using the accessory muscles to breathe, which is normal for this patient. And he looks good. Second thing, we inspect for patient's skin color, which is normal for his ethnicity, and the color of the skin, and looks like patient fingers, nails, and they are not look clubbing. No cyanosis seen visibly. So these are the things we inspect uh, for this assessment. So the next step is we do the palpation. So palpation are we done for checking for any kind of tactile stomatitis, for notable not any kind of palpable cryptus, uh, costochondrial tenderness, uh, and we'll do the respiratory excretion. So this is all we're going to do for our palpation. So to palpate the tactile infirmities, I'm going to use my hand lateral side, putting on the patient anterior chest, from the top of the right chest, and follow from the left and the right and the left from up to down, by asking patient to say 99, and observe the gonna feel the vibration and the intensity. If I feel the dull vibration, that resembles there would be any kind of lung consultation or any kind of problem going on with the patient. So we'll start our uh, palpation by using my palm of the hand for the patient, asking patient to say 99. Can you say 99?
99. 99. 99. 99.
Okay, and I'll follow the same thing behind the patient on the posterior chest. We can turn him, and same thing, we'll ask the patient, is 99?
99. 99. 99. 99.
And all the lung field from anterior and posterior, I did not hear any kind of dullness, and the vibration of 99 word was constant, and patient does not have any kind of lung consultation at this point. Now we move on to do our second palpation, which is a respiratory excretion. For that things, I will ask the patient to turn to his back, where I'm going to use my two hand holding at the 10th intercostal 10th rib, at the right of the spinal cord, and asking patient to take a deep breath in and out. To see my hand, my thumb will go with the patient inspiration and expiration, which tell us that patient respiratory pattern is normal and it's symmetrical. So if the patient have any issue, you will not able to see your hand moving symmetrically, and we can find out is there any other problem going on. So we'll perform the test by asking to turn the patient to the other side, and that's good. Yeah, we can see here, and this is 7th, 8, 9, and 10. This is a 10 intercostal space. I'm going to ask the patient, and hold it loose. Don't hold too tight. Hold it loose with the skin here. Can you take a deep breath in? Out. And take again. You can see my thumb is moving with the patient inspiration, coming back patient when he exhale. So I don't see any kind of asymmetrical here. breathing is symmetrical, and there is no problem. It's normal finding. And now we'll check for costochondrial tenderness. For that, I'm going to use my. You can use either one hand, two hand, but preferably one hand is good, so you can able to support the patient while you do that, and asking patient to if they're having any tenderness or pain while I'll palpate that sternal border where the ribs are connected, which is right here. Uh, any pain, any tenderness, sir?
No.
So patient denies any kind of pain or tenderness, which is normal finding. A patient has any pain or tenderness while I was palpating, patient would have tell us he's in pain. So at this point, there is no costochondrial tenderness is present. Now we'll go to our next step, which is percussion. So for percussion, we percuss the patient anterior and their posterior chest. Before we go to percussion, one more thing I forgot to tell you was when we do the respiratory expiration on the posterior side, you follow the same thing at the anterior side to make sure the posterior and anterior are symmetrical. Now we'll move on to our percussion, which is done on the anterior side as well as the posterior side by using the undominant hand middle finger, by using my dominant hand middle finger to tap on that. So the purpose of doing this to find out any kind of dullness that you feel. So if you feel any dullness, that will tell us that is the patient have any kind of lung fluid filled, or because the lungs are filled with air. So if any dullness which resemble any kind of mass or a fluid or any consolidation. So we'll start our assessment, and we'll follow with the it's right to left, so we can able to measure and compare the dullness. So normal percussion is resilient, which is normal finding, and if you hear in dullness, that is normal finding. So I'll start with the percussion by using, we start from the top here, where I can feel the ribs between the things, my hand goes. Here is the rib. And same thing we can do at the side and the other side too. So I did not hear any kind of dullness. I can hear all lungs feel area is resilient, and same thing I'll follow in the back while asking the patient to turn on the side, and we'll start from right to left. So step right here. And then the back side also, I did not hear any kind of dullness. Sound was resilient. Thank you. Now we'll move on to our next step, which is diaphragmatic expression. The purpose of doing that is to find out is the lungs, is diaphragm is moving symmetrically, or is there any kind of issue with the nervous system, or maybe any kind of tumor or any injury to the diaphragm. To do that procedure, I'm going to ask the patient to turn again to one side where I can percuss on the back side, on the posterior side of the chest, by using the same method, and from going from up to down, making sure where I hear the dullness, I will mark it, and then I'll ask the patient to take a deep breath and hold it to mark for the dullness. So let's start. We'll turn the patient, and I'm gonna use the pen marks to mark, because here in the office post I always have the patient to lift his gown up or shirt up so I can able to mark it, but because of the video I'm not going to expose my patient here. So we start with the 7th intercostal space, which is the end of your scapula, which is just 7th intercostal space, and then you can start. Take the couple of deep normal breaths, sir. Okay, that's good. Now take a deep breath and hold it for me. Okay, perfect. So right here, which I feel it right here, that's dullness. So I can mark it one here, and you can breathe normal. Now I'll ask the patient to breathe a couple of normal breath before we start. Okay, now can you take a deep breath and exhale it out? Take a deep breath, exhale out. Good. Okay, now hold it. Then we got again the same thing. One. Yeah, this is where I feel the dullness. So between those two space, I can use my measuring tape and mark it, which is, it should be right here. So it's 2 centimeter, which is normal. 3 to 5 centimeter is normal for the normal healthy adult. But if the patient diaphragmatic excretion, you can turn back. Diaphragmatic excretion come to 7 or 8. Sometimes the patient who are athlete or who are swimmer, you can see the diaphragmatic excretion bigger, little more centimeters. For my patient is 2, which is normal, and now we move on to our auscultation. So to do the auscultation, I will use the stethoscope, and then I'm gonna start auscultating the anterior chest, and then I'll go to posterior chest. And we're gonna use the ladder style, from going side to side, from right chest to the left side, from up to down. For that, we're gonna use our stethoscope. And to hear the high pitch sound, we use the diaphragm, and for low pitch sound we use the diaphragm bell for the voice. So I'm going to use the both diaphragm as well as the bell for this one. And we start from the upper chest. We start from the right upper chest, and then we go to the left upper chest. Then we go to right middle chest. Then we go to left middle chest. Then we go to right lateral for the right middle lobe, and then we go to left lateral. Then we go to right lower, and then right left lower here. And then we use the same bell and the diaphragm. I'm at the right middle, then the left middle, go to right lateral, go to left lateral, going to right lower, going to left lower. And you can use the bell to do the same thing. Right middle, left middle, right lateral, left lateral, right lower, and left lower. Now the same thing we're going to follow on the back side. Same thing we start from the here. Right here. So from the left to the right, left middle to the right middle, left lower, right lower, left lateral, right lateral. Same thing we use the bell too. Left to right, left middle to right middle, left lower to right lower, left lateral to left lateral. And patient lung sound clear in all the lungs, all the lung slope. I did not able to hear any kind of the adventitious noise or the sound which are wheezing, stutter, bronchi, crackles, rel, and crackles coarse, and the patient sound clear to me, and there is no abnormal lung sound at this point. Now we'll move on. We already done auscultation. I think we're done, right? We're done, right? So we're done. Auscultation is done. Any other things? I'm just thinking. No, I think we're good. So we're done with our cardiothoracic, sorry, uh, lungs and thorax assessment. We already did inspection. We did palpation. We did percussion. We did auscultation. On the last one is a specialty test. Which you're gonna do is egophony test, and we're gonna auscultate patient lungs anteriorly and posteriorly to find out is there any kind of abnormalities going on. So while doing that, I'll ask the patient to tell me a letter E, and I'm going to auscultate during that time. If I hear A instead of E, that means patient has either pleural effusion or patient has any kind of lung problem going on and need more evaluation. So we do the specialty test here. And the same thing we follow here is ladder method, going from right to left, from top to bottom. Can you see letter E?
E. 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 E.
I hear E for throughout the auscultation from anterior and posterior, and I did not hear any different word than the E. So patient is negative for the egophony test. And here we completed our complete assessment. Thank you so much.